Well, thank you very much. It really is a great privilege to be here and to speak at such an august audience. I hear a lot of reverb here. I don't know if that's is that audible to you as well? Dynamite. Okay. Not that I don't want to hear myself talk, but I really don't want to hear it that bad. So I am from Washington, so are you, but you probably are not flattered when you're confused with us, but we of course are. So it really is a great pleasure to be here, and my goal today is to talk a little bit about primary immune deficiencies, but my real goal is to try to make sure that I speak to all of the students and fellows and residents and junior faculty to let you know that we are open for business. And the National Institutes of Health is a terrific place to train. Although I happen to get trapped there, not everybody does. The draw to go back to Baltimore maybe wasn't quite the same as the draw to go back to Seattle. But the NIH hospital, it's a small hospital that is designed with the idea that we've got bench and bedside directly in proximity, and there are many opportunities for people to go there. There are fellowships in everything from endocrinology to infectious disease, and postdoctoral opportunities, training opportunities, some great opportunities for people when they come to the end of fellowship and want to get an academic position, but only want to spend a few years getting it off the ground. These are called assistant clinical investigators. And then there are these opportunities that I want to make sure you hear about, called the Lasker and the Statman. So we've got opportunities for medical students, for these assistant clinical investigators. The Statman Fellowship is a basic science opportunity. It's a tenure-track basic science appointment for people who are interested in pursuing more basic stuff. And then the Lasker Clinical Scholar Awards are 5-year intramural appointments, followed by 3 years of up to $500,000 a year to take back to an extramural location. These are competitive awards, but they are absolutely terrific. We've got several in our institute now, and they're in other institutes as well. So if you're interested in developing a clinical program, and you want to do things that allow you to take advantage of some of what the NIH has to offer, please don't hesitate to give me a call and talk about it. They're terrific opportunities. All right, so now trying to talk about primary immune deficiencies. I grew up thinking those weren't my problem. That was a pediatrics problem. Primary immune deficiencies are dealt with early in life. But, you know, as I go along, I am drawn back more and more often to the first Hippocratic aphorism, which is that life is short, the art is long, opportunity fleeting, experience misleading, boy is that the truth, and judgment difficult. And I want to show you a little bit. I'm going to try to give 3.5 vignettes of different diseases that I missed, and I want to make sure that you don't follow the same course. And I just want to set the stage and remind you that really, we are not dependent on antibiotics for survival, much as we might like them. And this is simply the projection of world population. Obviously, I wasn't there for all of it, but you know, there's a projection that we've been growing, and the intrusion of the introduction of antibiotics is hard to calculate on this. And I'll just remind you that the first one is the one that nobody ever thinks of, and it was Salvarsan in 1909, developed to try and address African sleeping sickness, ineffective for that, very good at that other sleeping sickness, syphilis. And it was 23 years until the introduction of sulfa drugs, and another 10 years until the introduction of penicillin. And yet, for most of us, to imagine a world in which we did not have antibiotics to interfere with the course of infectious disease is unthinkable. But as a species, we were doing pretty well. All of which suggests that we had worked out pretty good, not great, but pretty good mechanisms to prevent species destruction from infectious diseases and other things. For anybody who's interested, I'm going to just plug the book. This author actually lives in Oregon. I know that's a touchy subject, but it's a really good book. And Tom Hager has written some very fascinating things that really are at that interface of science and modern life. Okay, But so really, what's the elephant in the room here? The elephant in the room, this is not a Republican issue. The elephant in the room here is about why people get sick. If we're so good at survival, and we are, why is it that people get sick? And so what I want to talk about today are those primary immune deficiencies that tell us something about mechanism and pathophysiology. Now, you might say, well, that's not my problem. That's somebody else's problem. But I want to just remind you, the numbers don't actually suggest that. It suggests it's all our problems. So pretty much no matter how you look at it, the rate of getting immunodeficiencies around the world is about 1 in 10,000 humans. That's a staggeringly large number, 3 times larger than the number of cases of the rate of tuberculosis. So there are more diagnoses in children, of course, that's true. But keep in mind that there are about 4 million births a year in this country. And if that rate is true, there are 400 new cases being born. I promise you they're not all being picked up in infancy, despite the best efforts of our colleagues in pediatrics. And so if they were surviving, that would mean that there were 7,200 people around in late childhood. And if they survived longer than that, there would be thousands and thousands. And so this is not a trivial set of problems. Now you might be saying, well, yeah, but you know, those all show up in an easy way, but they don't. And so if you look at this one best, I think, study in a hospital-based population done by Charlotte Cunningham Rundles at Mount Sinai in New York, they simply culled through their clinical database and then went to look at how many people turned out to have primary immune deficiencies. And when you looked at people who had recurrent infections or chronic infections or severe infections, which of course is what gets all of us motivated, or abscesses, you know, abscesses just aren't normal, no matter how much we sort of say, oh, that's okay. They found primary immune deficiencies in up to 30% of those cases. So that suggests if you're an internist and you see that guy who comes in for his 3rd admission on your service, and when your other residents say, oh man, I know that guy, that's the guy you should be thinking about. Yeah, you might say, well, you know, he's a drinker or a shooter or whatever it is that people say these days. But you ought to stop and say, wait a minute, does he have another underlying problem? So I'm going to give you now real examples. And these are real examples that come out of my hospital, just so that you know that we actually have patients there. So first one, real case. 23-year-old previously healthy woman, a lacrosse coach, coached the team that beat my daughters. Okay, so I was prejudiced here. 23-year-old, very healthy young woman comes into an emergency room 4 hours after a 3-mile run. She goes into the ER and says, I think there's a desk on my chest. Very good ER doc comes in, says, no way, there's no desk on your chest. And what do they say? You know what they say? They say, oh, you know, you're a young girl. You were up in New York partying with your friends. I bet you just are either anxious or you've got acute mono. I don't know where mono comes into this, to be frank. But they said, just go home. Don't bug us. Don't worry about it. Okay, first admission. I'm going to my 2nd admission rule here. 2 days later, she's back. And now she's really back. And she's hypoxic. And she's febrile. And now they say, okay, now there's probably a problem. And you can see here what the problem is. Now, I want to be clear. This was the hospital right across the street from us. They did everything right. I'm not criticizing. They did everything right. They gave her, they decided this is community-acquired pneumonia. I don't know what that term means, except that we've given up thinking. I mean, that's great to just say, oh, you live in a community, you have pneumonia, therefore it's a community-acquired pneumonia. Give me a break. Come on. We are supposed to be smarter than that. But anyway, so they treated her for that, and that didn't work. And then they said, well, maybe this is a hypersensitivity pneumonitis. So they gave her a lot of steroids. Well, that was fine. That didn't work either. Then they did a bronchoscopy, and that didn't show anything. And then they did exactly the right thing. They went to a visually assisted thoracoscopic surgery. Now, I don't know about in your hospital, but I can tell you, getting somebody to go and violate the chest of a previously healthy 23-year-old, it's not easy. No surgeon says, oh yeah, I can't wait to do that. So she had to be pretty sick, and she was pretty sick. And she was so sick that in the immediate post-op period, here's a healthy young woman, 10 days now after walking into the ER. She is tubed, she is vented, she is proned, and she is hypoxic. And now, inevitably, it's Saturday, because these things always happen, you know, first on Friday and then on Saturday. And it's Saturday, and the pathologist gets the slides out, and he says, okay, I see the 5 alveoli that are being aerated. Now I know why she can't breathe. And then he sees this area here that's a pyogranuloma. That is, it's, you know, neutrophils in a granuloma. And he goes back to check the micro, and he says, it's growing aspergillus. Now, the pathologist is nervous, right? You know it's bad when the pathologist is there on a Saturday and the pathologist says, now I'm nervous, right? What does he care? He got glass in front of him. He's nervous because he knows something's wrong. And so he starts calling around to people. And so now you have to help me, because he's calling around, he's worried, what is going on? Because he's got invasive aspergillus in an otherwise normal host. So here's your differential diagnosis. Could this be a bad case of allergic bronchopulmonary aspergillosis? Is this a funny example of cystic fibrosis? Is this some strange element of lymphocyte dysfunction? Is this a phagocyte problem? Or is this yet a new manifestation of acute HIV contraction? What is it? What is it? Well, so you know it can only be one problem here, right? Because it's only phagocytes that care about aspergillus. Lymphocytes, despite what people say about them, and I know people say great things, but they don't care. They don't know from fungus, okay? That's not their business. Cystic fibrosis, you guys see a lot of cystic fibrosis here, but they get a lot of aspergillus, but it tends not to be invasive. Lymphocytes, forget it. Allergy is bad, and people can get bad allergic problems, but it's not invasive. And then acute HIV is, of course, something that does lots of things, but acute HIV is not about fungal susceptibility. So that leaves you with only one problem, and that is that it's got to be a phagocyte problem, because phagocytes are what control these invasive molds. So I just got to remind you, because nobody pays attention to them, right? Everybody can tell you what somebody's ANC was, but that's just because they care about number. They don't care about quality. Really, and talking about quality is so hard. And people know what the CD4 number is, but they don't know about the phagocyte numbers. So remember that phagocytes comprise a whole variety of cells. Neutrophils are the ones we're going to talk about. And what makes them so cool is that they've got these preformed granules that are full of nasty little enzymes that are there to kill virtually anything that you encounter. Now, normally you make 10 to the 11th neutrophils a day. But just like that French bread that you buy in the bakery, you know, it's only good when it's fresh. And so the half-life in the circulation is 7 hours. You're turning over your neutrophil population 3 times a day, because it's just that important to have them there and working properly. Now, what do they do? I'm just going to give you a schematic of what these guys do, because, you know, you just have to gloat in the beauty of it. So this is my schematic of a neutrophil. This is the phagosome. There they got granules off in the cytoplasm. So when fungi or bacteria get ingested by the neutrophil, what does that do? It makes the granules come and fuse with the phagolysosome. And when they do that, this deposits this complex of 91 and 22 into the wall of the phagolysosome. At the same time, these proteins that are off in the cytoplasm, 47, 67, and 40, come together and they now merge with that stuff on the membrane. And so you've got a complex here that's made up of these 5 proteins. And what those do is that they steal from NADPH in the cytoplasm, they steal an electron and they donate it to molecular oxygen, creating superoxide. This stuff was worked out here by Seymour Klebanoff. Here, University of Washington's got an extraordinary history around this disease. And that electron is donated to molecular oxygen. Superoxide dismutase then converts that to hydrogen peroxide, and myeloperoxidase, which is an enzyme that was hanging out in this vesicle, myeloperoxidase converts this to hypochlorous acid or bleach, finally explaining why white cells are white. All right, you're a tough crowd. You're a tough crowd. But I'll be here all week. It's okay. Now, why? So everybody thought when this pathway was worked out, and I think it was Seymour's work that originally said, look at that. Streptococci are killed. Staphylococci aren't. And that's because streptococci make catalase. And catalase destroys this. Staphylococci make catalase, streptococci don't. And so staphylococci are destroying this, and therefore, catalase positive organisms are the ones that cause disease in chronic granulomatous disease. But in fact, what I think is really going on is that when you create superoxide and put a charge in the phagolysosome, that's got to be rectified. It can't sit there unopposed. And so a large potassium channel opens, potassium comes in at a huge concentration, and that potassium then liberates these enzymes that have been sequestered here in the background, elastase and cathepsin, and that potassium liberates those enzymes, and those enzymes actually come and do the actual killing of bacteria and fungi. In part, that is likely to be more true because defects in myeloperoxidase are surprisingly common and rarely associated with any clinical disease. Well, so mutations in any of these 5 genes, any of the 5 genes that code these proteins, lead to the same problem of inability to create superoxide and therefore inability to create this. And this is the disease that we now know as chronic granulomatous disease. I'm only going to speak for a moment about this, but this disease is surprisingly important because these patients tend to survive now. And with the availability of really good antibiotics, these patients survive, just like this young woman, to present in adulthood. So you got to think about it. Now, in North America, you have to think here, any of these 5 infections, staph, serratia, Burkholderia, Nocardia, or Aspergillus, should always, always, always make you stop and think, could this person have chronic granulomatous disease? And if you see a bad infection with any of these things, obviously, if it's Burkholderia and you're at UW, you're going to be thinking about cystic fibrosis, and you'll think about it with any of these. But if it is invasive, you've got to exclude chronic granulomatous disease. And in North America, virtually all of the infections, all of the patients get these. Now, if you notice here we have a wall that separates us from the rest of the world, and that's where you get salmonella or BCG infections, also bad problems in chronic granulomatous disease, not bad problems here in the United States. And then for those of you who are interested in what it really means to be an infectious disease consultant, I'll just remind you, it's the ability to say Chromobacteria violatium, Francisella filamenorrhagia, or Granulobacter bethesdensis. If you say them very fast, then you can actually bill more. But these are organisms that are pathognomonic to chronic granulomatous disease. And when you encounter them, and you will, you encounter them in brackish water. So these organisms are what are seen anywhere from Disney World to the Bay of Fundy. I don't know how much you see out here. I actually don't know about case reports of Chromobacterium or Francisella from out here, but they certainly are seen in the East Coast in estuarian settings. Anyway, so why did this girl choose that day to walk into the hospital with that pneumonia? And it was because her father had decided he wanted to have a nice garden that year, so he hired a dump truck to come and dump mulch on the driveway. And when mulch is on your driveway, you got to get it off. And so she went out there with her dad, spreading the mulch down on her haunches, spreading the mulch under the bushes, got a real lung full of this stuff, and then went out for a run, which was why she had an acute onset. That was partly allergic, partly invasive, and then why 2 days later she was in desperate straits. She had the P47 version of chronic granulomatous disease, not important for today's discussion. And what we did was to transfer her from that hospital over to our hospital. We gave her voriconazole and caspofungin, as well as steroids. And it's critical to be thinking, nowadays, nobody thinks twice about the idea that in severe pneumocystis, you better be given steroids along with your antibiotics. Or in severe tuberculosis of the, meningeal tuberculosis, you better be given steroids with your antituberculous therapy. And nobody really thinks twice about the fact that when you're treating bad HIV and you get iris, you need to give something to suppress that. But try and persuade people to give steroids in bad infections and primary immune deficiencies. Oh my God. You are just suggesting that there has to be like regime change. But now we got her over all that. She is now back to running 4 miles a day, has 2 kids, and is fine. So it's an example of what turns out to be a internationally present problem that had not been recognized before. Not because it didn't happen, because we never put it all together. And this is now referred to as fulminant mulch pneumonitis. And it is something that comes on, and when people get it, it's really bad. And we found it. These are the ages of presentation. You can see from fairly young to only moderately young. And notably, it only occurs in the fall and summer. And that's not so surprising. This is true in every hemisphere. When you don't have a lot of organic decaying matter around, mulch, peat moss, digging, people don't inhale mulch this way. Important to be thinking about how you use steroids to get them better. And the take-home message from virtually all primary immune deficiencies is that when the control of infection is impaired, the control of inflammation is impaired. And so you're almost always trying to think through, how do I control both of those at the same time? And one other manifestation, I just want to make sure that I highlight some of the critical UW issues here. One of the critical manifestations of chronic granulomatous disease now was published here in 1973 by Hans Ochs and Marvin Emmett. And what they realized took us 30 years to come back to. They realized that in almost half of these patients, they get bad inflammatory bowel disease. It can be fistulizing, it can be destructive, it can be really a pain in the inflammatory bowel disease. And they knew that it was happening in up to 50%, and it took us 30 years to come back around to putting big numbers onto that, so that we now know that when you diagnose this disease, you got to start looking for these problems. Okay, that's all I'm going to say about chronic granulomatous disease, but I promise you it's out there, and I promise you that there's more of it wandering around in Seattle than you think. Okay, next. Woman is referred to me in 1992. And she's referred because she's got hundreds of nodules all over her body that are chock full of Mycobacterium avium. You can see where it's draining. At the same time, she says, I got this funny headache and a little bit of double vision when I look to the left. And sure enough, on the MRI, she's got a mass in her posterior orbit. And when we went and took that out, it was an EBV positive smooth muscle tumor. Those tumors only occur in HIV, and she didn't have it. Now, her course of illness was a little bit surprising. She had had severe warts as a young woman, but they had been managed. She developed a pneumonia in her 30s for which she received a lobectomy. Not our recommendation, I want to be clear. This is not how we treat pneumonias at the NIH. But she had, if somebody went to a lobectomy for a pneumonia, that tells you just how difficult it was to treat. And then in her late 30s, she developed disseminated M. avium. And when she came to see us, we noticed that aside from all these issues, in the peripheral blood, she had no monocytes, no B cells, and no NK cells. Despite that, she had normal levels of immunoglobulins and detectable numbers of T cells. Well, we treated her at that time with interferon gamma, which we were really excited about because it was such a cool thing very early in its discovery. And then shortly after that, she developed chronic myelomonocytic leukemia, and then went on to a bone marrow transplant. And this was in the days when bone marrow transplants really weren't that good, despite all the efforts being done here by Donald Thomas and others. And then she came back to us for an autopsy. Now, can I just stop for a second and ask, how many people here have had patients come back for autopsy? How many people have decided it's not worth getting an autopsy? Yeah, I know, don't put up your hand. But, it is a painful reality that we do so few now. And I don't know about your academic medical centers, but virtually everyone I go to, nobody does autopsy. For all the reasons, oh, it's painful, I don't want to talk to the family, it's too sad, you know. The pathologists don't want to do it. Some places they want to charge for it. Oh, I know everything, I got the CAT scan. I'm telling you, you don't know what you don't know. And if you don't know, you're flying blind. And we were flying blind on her, and she came back for an autopsy. And what we found was that at autopsy, despite the fact that she had had no B cells and no NK cells and no monocytes in her peripheral blood, she had plenty of macrophages in her tissue. And she had plenty of plasma cells in her tissue. So she didn't have them in the circulation, but she had them in the tissue. How could that be? And we puzzled about that for quite a while. Along the way, because you know, there had been, you know, we had been thinking that there might be genetic reasons, we looked at her family history, and in fact, while we were trying to work her up for transplant, we noticed that this, our index patient, had those problems I mentioned. Her 31-year-old sister also had had warts, mostly genital warts, starting in late adolescence, and also had no B cells, no monocytes, and no NK cells. She was 31. She had a couple of kids. She was doing okay, but had those problems. Interestingly enough, their mother had died at 54 with chronic myelomonocytic leukemia and disseminated mycobacterial disease. So all we knew for sure was that it was a dominant pattern, and that meant it had to be a single gene. And that really meant if it was a single gene, we ought to be able to track it down. Now, that started in 1992, and it wasn't until 2011 that we identified mutations in this gene called GATA2 as being responsible. And that sort of reminds you that NIH can also stand for not in a hurry. And I take no pride in the fact that it took that long to sort this out. But as I try to tell you a little bit more about it, I think you'll see that it was a complicated story. At the same time that we were doing that around this family and others like her, Marshall Horowitz and his colleagues here at UW were tracking through other families, not who had bad mycobacterial disease or because they had no NK cells, because these people were developing a familial myelodysplastic syndrome with AML. And Marshall had realized that these families had a dominant pattern of transmission and had gone through a different technique to recognize that these patients also had mutations in GATA2. Now, as is almost always the case, we as physicians describe bad problems first, and then when we come up with diagnostic techniques, whether it's to find out who's got Epstein-Barr virus or who's got HIV, or to find out who carries genes for different traits, we start out describing obvious severe traits, and then we begin to have this phenotypic expansion. And GATA2 is one of these diseases that really has been very much of the blind people examining the elephant. And so, you know, Marshall's team saw AML. We now know that it can also cause ALL. My team found mycobacterial disease because that's what we were looking for. That wasn't smart, it was just there. And other teams have found various things, aplastic anemia, MDS, NK, alveolar proteinosis, and all of these other problems, all of which are being caused by the same problem. Now, I know that you see this here because I've seen some of those cases that you see here, and I know how long it takes them to get diagnosed. It's years, and it's painful, and I'm going to tell you something about that. So this young woman was in her mid-20s. She works up in Vancouver and had extensive warts over her hands and feet. And I mean extensive. These are the small ones. Much more tragic is what happens again and again. And I cannot reiterate how painful it is to see young women come in. They don't come in to me saying, oh, by the way, I've got a little HPV. They come in to me referred from their gynecologist who says, you know, I've done 3 vulvectomies on this young woman, and it keeps coming back. It's embarrassing to have the gynecologist tell you about immunologic defects. I mean, no disrespect to the gynecologist. But if you see severe recurrent HPV in a young woman, cervical, vulvar, vaginal, you got to stop and say, why is that happening? These viruses are everywhere. Why should she be getting that? It can also show up as disseminated histoplasmosis, disseminated M. avium. This girl, the sister of the man who showed up with this histo, died at 12 of disseminated varicella zoster. The mother of this man and this girl had only unilateral lymphedema with a lot of flat warts on her leg. Finally, this is what an EBV smooth muscle tumor looks like. 28-year-old man from the Philippines who came in and had this lesion seen. This is EBV staining on his liver, chock full of Epstein-Barr virus. Now, these are all manifestations of GATA2 deficiency, all of which say that when your NK cells don't work, and your B cells don't work, and your monocytes don't work, you've got certain levels of susceptibility. One other thing that is common in this disease is subpleural blebs. This can begin years before any disease. If you've ever seen a CT scan of somebody in their 20s or 30s who's got this kind of funny pleural and interstitial emphysema, stop and think, why should that be happening? What is going on? And you want to think about it because they can go on to develop this severe complication of pulmonary alveolar proteinosis. This is in people who do not have GM-CSF autoantibodies. All right, well, to sort of conclude then, with GATA2 deficiency, one of the hallmarks, by the time they get symptomatic and by the time they come to you, if they've got cytopenias in the peripheral blood, they've got even more cytopenias in the marrow. And this is just an example of a hypocellular marrow. It should look like this, and here it looks like that. Remember that your marrow should be about 100 minus your age. So if you're 20, you ought to have a very cellular marrow. If you're 60, you have a less cellular marrow. This was a person in her 30s who had a pretty hypocellular marrow. And there's some characteristic anomalies of megakaryocytes. These nuclei are spread too far apart, and the megakaryocyte isn't quite mega enough. It's a micromegakaryocyte. You can see here again a small megakaryocyte. And these are very common findings. So if you have a marrow and you're wondering, you got to go back and say to the hematopathologist, what did the megakaryocytes look like? Did you see anything anomalous there? Well, all right. So now we're 20 years into this disease, and what we see now is that, or 25 years really, it's now been called by 5 different names in the literature. We called it monomax syndrome because it had monocytopenia with M. avium infection. Marshall's team called it familial MDS and AML. It's also been called dendritic cell, myeloid and lymphoid, NK lymphoid hypoplasia, or Emberger syndrome. All of these are simply names, all of which refer to one disease, which is GATA2 deficiency. Of course, the more you look, the more it turns out that it shows up other places as well. This is the most common cause of pediatric myelodysplastic syndrome, especially if it's got trisomy 8 or monosomy 7, but it can present as all these other myeloproliferative and lymphoproliferative conditions as well. The reason you want to try and make this diagnosis is not to be able just to prognosticate, but it's because intervention is really valuable. And bone marrow transplantation has been extraordinarily successful. So, and this is effort led by Dennis Hickstein, one of your graduates, and a man who has turned out to be a fantastic collaborator at the NIH. And now in our haploidentical and our matched related donors, we're doing great in terms of the transplant success. And even with unrelated donors, we're doing okay. We're trying to get better. And Dennis has been working very hard to make that happen. So you want to make the diagnosis so you can preempt the problems and get to these people before they develop leukemias. So this is an example of a disease that really is quite extraordinary. Transcription factors like GATA2 control lots of things, and so they control other transcription factors here, histone deacetylases, endothelial factors, angiopoietic factors. These people have one gene that controls many different processes, which explains how it can have such a complex phenotype. Fascinating. So I just want to now point out that technology is changing. And to try and make a phenotypic diagnosis of GATA2 is great. But what you really need to do is the genotypic approach. So in the old days, we would be doing genetic sequencing here using the old gel technique, which was a lot of fun. Many of us in the room spent hours and hours doing this. Nowadays, of course, everything is being done through next generation sequencing. And so whereas 20 years ago, or even 10 years ago, it made sense to say, I'm going to check that gene for that problem, that doesn't make any sense anymore. That'd be a waste of your time. And most of your technical people would say, don't waste my time asking me to check one gene. I'm willing to check 100, 1,000. I'll do a whole exome for you, but I'm not going to do one gene at a time. And I think the technology has moved on. And, you know, that is just the nature of technology. And the technology of telephonics, we might dislike the fact that we are now at the beck and call of our cell phones every single moment of every day. But ain't nobody in this room going back to the old trunk system or the candle system or the wall phone or even the cell phone that I started out with. Ain't gonna happen. You can't go back from where you are. And so the technology now is, we can't be sitting around wondering, should we be sequencing? No, that day is past. The day upon us is, you better be sequencing everybody soon. And I promise you, 5 years from now, that's what you're going to be doing. It will be delusional to think that you can do things without knowing what's going on. You need that for a tumor. You wouldn't tolerate an oncologist who said, I don't know, it looks like a tumor, it looks like it's in an organ, I think we'll just treat it. No. Why should we tolerate that about the host? And I think that's where we're headed. All right, so I'm going to come into the home stretch here and try and point out that I'm very interested in genetic diseases. I think that they're pretty cool because you can find one problem that you can identify and you can pursue. Genetics has opened up the door to mechanism and pathophysiology, but that's not everything, much as I would like to have thought so. So I thought when we worked out all these genetics that we would know a lot about what was going on. But this person told me that I was wrong. So 60-year-old woman from Vietnam, survived the war, came out on the boat lift, lived in a camp, wound up going to Tennessee where she had a job, had a bunch of children, had a business of her own, and then had a year of progressive weight loss, went into her doctor, said, whoa, you got cancer. You're probably going to die. I'm not making this stuff up. I'm not imaginative. And he said, but I think we'll figure it out. I needed bone marrow, and it was chock full of mycobacteria. And then he transferred her to Vanderbilt, and they worked on her, and they saw that she had these lesions here, which had been developing. And they looked at those, and they tried their best to treat her. They did everything right, and it didn't get better. And these lesions here were due to these lesions here. You can see this osteomyelitis that is rupturing out through her skin. She's got severe progressive disease. She weighs 85 pounds when she gets transferred to us. So I'm interested in genetics. I'm interested in fundamental underlying mechanisms. And so there are these syndromes that are lumped together as Mendelian susceptibility to mycobacterial disease. And all of these genes here are thought to be involved. And they're important because mycobacteria infect macrophages. That leads to the production of IL-12. That goes through its receptor here, the 12 receptor, to lead to the production of interferon gamma. That then goes through its receptor on every nucleated cell and turns on the production of tumor necrosis factor and turns on magical pathways that kill mycobacteria. We know that's all true because all these genes with these red stars have been shown to be mutated in people with disseminated non-tuberculous mycobacterial disease, which is what we looked for in her. But we couldn't find anything. And we couldn't find anything because that's not where her problem was. And so I just want to remind you, as I mentioned that extrapulmonary disease is about mycobacterial control, but it's not only about mycobacterial control. That's how it sort of gets marketed, and when you use the term Mendelian susceptibility to mycobacterial disease, that helps elide the fact that the same people in the same compartment get salmonella, cocci, histo, and some Burkholderias. So just keep in mind that the pathway we're talking about is the pathway that controls intracellular killing of organisms that exploit that macrophage niche. So in this woman, where is the lesion? Well, it wasn't in any of those genetic sites. What she had is an autoantibody to interferon gamma that blocks interferon gamma signaling and therefore mimics directly the problem of being unable to signal through the receptor because she's bound up all of her interferon and cannot use it. Well, the recognition of these autoantibodies to cytokines, I don't know, has anybody seen these here? You've had some, Conrad? I mean, so these are, this disease is predominantly in, East Asian women, and these women have high titer antibodies, and they can be ameliorated with rituximab if their disease is refractory. So you want to be thinking about this in these women who come in with severe disseminated mycobacterial or other disease. But once you start down this pathway and you say, wow, an autoantibody to interferon gamma, that's sort of interesting, then you got to start wondering how many other ways are there to inhibit infection susceptibility by forming antibodies. And so antibodies to IL-12 are associated with severe disease. Antibodies to GM-CSF are particularly interesting because they cause not only pulmonary alveolar proteinosis, they also lead to susceptibility to Cryptococcus and to Nocardia. I want to make sure to mention the Cryptococcus in particular here in Seattle because when we noticed this first case, it was incidental noticing of it, we noticed that first case and we went back and said, gee, crypto, antibodies to GM-CSF, maybe we better go back and look at all of the banked samples we have of cryptococcal meningitis and see. And so we went back to Jack Bennett, who had a freezer full of samples going back decades, and we realized that several of our Cryptococcus cases had high titer autoantibodies to GM-CSF, just like in those people who had pulmonary alveolar proteinosis. But then we went just a step further and said, well, is it true for all crypto or just some crypto? And it turns out that it's almost exclusively in C. gaddii, a very important topic here in the Northwest. And so if you have somebody who shows up with C. gaddii meningitis, boy, I really suggest you think hard about checking for this. The reason to check for it is not that it's going to change your treatment for that individual. But what it does mean is that that individual has an autoantibody to GM-CSF, and that individual is at very high risk for going on to develop pulmonary alveolar proteinosis. So, again, I'm just a crank, you know, I mean, I don't mean cranky, I mean a crank. You put in the coin, you turn the crank, and something comes out. So when we saw this guy come in, a Marine who had survived tours in Afghanistan and Iraq, he came in after having had an acute seizure. He went into a hospital where a brain biopsy was done and then mistakenly got cultured, and any of the infectious disease people know exactly what I mean by that, and the culture grew Nocardia. And eventually they called me up and said, how in the world could that be? And at the time, his chest CT was pretty clear except for a few scattered ground glass opacities. Well, his Nocardia brain abscess is cured. He's never had another infection. But his lung disease has progressed, and we've now had to put him on inhaled GM-CSF to try and treat the alveolar proteinosis. So just a reminder that when you get funny infections, stop and look for that. Now I'm just going to conclude by saying, you know, just because we find these things in rare diseases doesn't mean that they're not important in common ones. So in this country, lupus is in 0.1% of the population, rheumatoid arthritis in up to 1%, and then Sjogren's in a slightly higher percentage. What is going on with diseases characterized by autoantibody formation? And I'll just summarize a large piece of work done by our colleagues at the National Institute of Arthritis and Musculoskeletal Disease and colleagues at the University of Athens in Greece. And when we look for autoantibodies to interferon gamma in patients with lupus, and we look at the score of their disease score, What we see here is that if you're antibody positive in this column, you're actually sicker than if you're antibody negative. That is, they are expressing more interferon alpha related genes because interferon gamma antibody allows more signal to go down the alpha pathway. In contrast to that, if you look at people who have autoantibodies to interferon alpha, those people have milder disease than do those that have, those people have milder disease than do those who have the antibodies to interferon gamma. That is, these autoantibodies are out there, they're modifying disease, and they're in the background, and we never look for them, so we never quite figure it out. So these anti-cytokine autoantibodies are common in lupus. They may alter the course of disease. Anti-type 1 or anti-alpha are associated with milder disease. Anti-type 2 or anti-gamma associated with worse disease. And they may influence the response to immunomodulation. So I just want to conclude about this, and I really am about done, that these anti-cytokine autoantibodies are almost all in adults, not exclusively. And when you have the anti-interferon gamma, it's mostly mycobacteria, but I think that's mostly where we've looked. It's almost exclusively in East Asian women born in East Asia, not East Asian women born here, and not East Asian men born there. I can't explain that. There are associations with HLA, as you might expect. The anti-IL-12 antibody has been identified in one case of severe persistent Burkholderia bacteremia, and the anti-GM-CSF autoantibodies are described with Cryptococcus and Nocardia, as well as pulmonary alveolar proteinosis. These are important to recognize because not only do you treat the infection, but you have an option to treat the antibody itself. I just want to remind you there are other autoantibodies out there. Anti-IL-6 autoantibodies have been associated with severe staphylococcal disease. Anti-erythropoietin antibodies associated with pure red cell aplasia, very common in thymoma. Anti-GCSF antibodies with neutropenia, alpha, and so on. There are many more coming. Stop and think about the last time you asked a laboratory to look for something that wasn't on the list. Those are the things that are out there. All right, so I've tried to talk today about 3 different problems that I think are out there in adult internal medicine. They're the things that I know I missed for a long time. These are, I talked about an acute adult presentation of chronic granulomatous disease, the complex spectrum of GATA2 deficiency, and then anti-interferon and other anti-cytokine autoantibodies. But I tried to talk about these here because I really know that they're there. I know in your complex patients who are coming back to your clinic again and again, you got them. And I promise that if you look, you can find them. And if you're trying to figure out where to go to do these, please don't hesitate to send me an email. I don't promise to respond immediately, but I will get around to getting back to you. This is what we live for at the National Institutes of Health. So I just want to conclude by saying that this spectrum of diseases really does help exemplify what is there in that first Hippocratic aphorism. Life is short. You know, this field, immunodeficiency, has only been around since 1952. And our lives, many of our lives, span this entire field. And its expansion has been dramatic over the last decade. But life is short. This is going to keep going. There's a lot more. We've missed many of the opportunities we've had, but we're going to keep on trying. It's easy to be misled. Phenotype is the lens through which we used to see things, but I think that's not where we're going to go. And where judgment is going to be difficult is that as we move to genotype, trying to decide how do we act on that genotype is going to be difficult. Look at how long it took us to decide on how to handle HIV seropositivity. And I can tell you that 20 years ago, the decision was you don't do anything until the CD4 number drops. Now, people would look at you like you had a rock in your head. What, you want to wait for them to get sick before you treat them? What, are you stupid? We don't want to be caught being stupid again. But judgment changes as technology changes and as our understanding of the disease changes. And our understandings of these has changed a lot. And so we've changed a little bit from trying to use animal models and these sorts of indirect methods to a much more direct approach. And so our motto here is to go person, because that's where we're going to find it. We've got human diseases. Now we've got human tools, human models. We need to use them. Thank you very much.